So I'll be continuing the conversation that we just started, talking about the biomarker that we probably know and love most, high sensitivity C-reactive protein, and then a little bit also this theme of, more specificity in how we follow people thinking about imaging cardiovascular inflammation, and then we'll continue that discussion with the next talk. These are my disclosures. So C-reactive protein was discovered many years ago in 1930 by Tillett and Francis, and it's called C-reactive protein because it's a globulin that precipitated with the C polysaccharide of pneumococcus. So very early on, as Dr. Libby mentioned, identified as a biomarker of infection and inflammation, and you can see this pentamer here on the right. And also very early on, although we're still talking about this today, it was recognized that C-reactive protein was elevated in patients who had disease, cardiovascular disease, and this is by Krupp and Shackman in the 1950s, where they took patients who presented with acute myocardial infarctions, and back then the way they diagnosed it was with signs, EKG signs, symptoms, and really crude measures like fever, leukocytosis, fibrinogen, and C-reactive protein, and saw that C-reactive protein quickly rose in patients who had signs of myocardial necrosis or transmural infarction or Q waves on the EKG. Very striking, patients in their 40s. And so while there was this association between C-reactive protein and cardiovascular disease, of course the question was this all because of the myocardial necrosis and cardiovascular disease, or could CRP be this signal? As Dr. Libby told us about this, it had been recognized long before that inflammation was a precursor to the development of vascular disease. And so that was a question. And there were a series of studies that helped us figure this out, that there was a biomarker that you could measure in apparently healthy people that predicted their future risk. And so this was the Physicians' Health Study, which randomized over 20,000 male physicians to aspirin or I think it was beta-carotene, in the 1990s, and showed that aspirin was effective. And this is a study, a nested case control study, a prospective nested case control study within that Physicians' Health Study, where Dr. Ridker and his colleagues measured C-reactive protein and found this important relationship between CRP and cardiovascular disease. Between patients who developed cardiovascular disease, about 500 who had events, and controls. And you can see compared with those who had CRP in the lowest quartile or the referent range, that those who had CRP in the highest quartile, you can look here at the placebo group, had the relative risk of myocardial infarction that was 4 times higher than those in the first quartile, and that was also lowered with aspirin therapy. So that effect was modified by aspirin therapy, and aspirin was effective in this group. But that was also that study was only in men, and they were able to extend these findings in the Women's Health Study. And so we're talking also about trial design, and these two trials illustrate this important point that we talked about, why it's so important to take into account disease in the population under study when you're designing trials. The Women's Health Study had nearly double the number of women asking the same question about the efficacy of aspirin. And so they were able to, in a similar fashion, design a prospective nested case control study measuring CRP in those patients who developed cardiovascular events and in a control population. And here they looked at not just CRP, but a dozen biomarkers, so including amyloid A, soluble intracellular adhesion molecule, interleukin-6, homocysteine, and lipoprotein little a, and then this ratio of total cholesterol to HDL, among others. And CRP was that biomarker that was most predictive or still significant when adjusted for other biomarkers. So you can see here with the relative risk of 1.4 and adjusted a relative risk of 1.5 for future cardiovascular events. And so if we, is this the pointer? I don't know if this is the pointer, Michelle. Here? Oh, here we go. Oh, here we go. Somewhere. Here we go. There we go. So you can see here, if we look at, within strata of CRP and total cholesterol, that women with the lowest total cholesterol and lowest CRP were at lowest risk. But when we look at women with low total cholesterol but high CRP, that they have a relative risk here that's between 3 and 4 times, those with low total cholesterol and CRP. And we're lucky to have now 30-year follow-up data with the same cohort, women's health study. Some people would say, or something you might hear in practice, is that CRP is not reliable. It changes, it rises quickly and changes rapidly, and so it's not a reliable biomarker. And I think something that helps refute that is this data that was published last year, showing that a single measure of CRP predicted risk over 30 years of longitudinal follow-up in these women. So this is a cohort that was over 27,000 female health professionals. And you can see here a hazard ratio for the highest quintile of high sensitivity CRP was 1.7. And when we again, not a dichotomy, but I think it helps us, we're all very, very comfortable with thinking about LDL cholesterol and lipid-related risk. But when we, think about this lipid-related risk in this cohort, the hazard ratio for LDL cholesterol was 1.36 when compared to CRP. So a single measure predicting risk over long-term follow-up. So when we think about primary prevention and how to assess lifetime or long-term risk, a biomarker that could be helpful. And of course, this led to these findings led to the design and conduct of the Jupiter trial, which, as we just talked about, selected patients with elevated CRP, those who were thought to benefit, and treated them with rosuvastatin 20 milligrams, so 17,800 patients. And as we know, this trial was stopped early for evidence of benefit and demonstrated a 44% relative risk reduction in the primary endpoint of major cardiovascular events, as well as myocardial infarction, stroke, revascularization, and death. Now, we just talked about some of the criticism as well. Those were patients who were selected for inflammation, and statins both lower LDL cholesterol and lower CRP. And right now when we talk about prevention, I think we're all pretty comfortable with treating patients with statin because of their, pleiotropic effects and, salutary effects. But if we think about this concept of, so now that we've treated LDL cholesterol, what else is there? Thinking about inflammatory risk, I'll go through some studies that really, I think, get us thinking more about this concept of residual inflammatory risk once we've treated LDL, or in patients who we've treated for their LDL-related or lipid-related risk. These are data from the CLEAR Outcome study. So the CLEAR Outcome study was designed with bempedoic acid, patients with statin intolerance, and majority of these patients had existing cardiovascular disease, close to 70%. But it's important to remember that about 30% were in this high-risk primary prevention cohort, and that included patients who had elevated risk as defined by the Reynolds risk score, which incorporates c-reactive protein. And so if we look at this data, we see that, so these are contemporary patients. The median LDL, I think, is about 130, CRP about just over 2. We can see Similarly, when we look at strata of or quartiles of CRP, that those patients in the highest quartile of CRP had about a twofold increased cardiovascular mortality compared to those the referent group or the lowest quartile, and the same relationship did not exist for LDL cholesterol. And when we look at these categories that have become clinically relevant. So patients, and we're also very close to the medians in this cohort, that those with an LDL greater than 130 and a CRP greater than 2 were at elevated risk of cardiovascular mortality when compared to these other groups. So those with LDL less than 130 or low CRP, or even those with LDL greater than 130 but low CRP. And there are other studies we can sort of triangulate this data with, including those with very low LDL. So, where patients who are LDL, right, average LDL more in the 70 range in the Fourier trial, which is patients with stable cardiovascular disease. So if we look at the placebo group in that trial, we can see that patients, the highest HSCRP group, so they were divided here into 1 to 3, and greater than 3, based on the CDC or HA guidance for measuring CRP. We can see here that the event rate for this group is nearly 18% over 3 years, those with the highest CRP, for cardiovascular death, MI, stroke, unstable angina, or coronary revascularization. And that you can see this gradient of risk is really consistent across all these endpoints: cardiovascular death, MI, stroke, revascularization, unstable angina, and all-cause mortality, though you can see the highest spread here is for all-cause mortality and this combined endpoint. And again, when we think about the patients that we see in practice nowadays with very low LDLs, right, sometimes you get these LDLs measured or calculated from your lab that are 0 or negative. So when we think about those patients, right, sometimes you see those patients and you think, okay, I've got the LDL down to 10, we're all, we're done, pat myself on the back, we all did a good job, they're taking their medication. But when we think about those patients, in the context of these data, with low LDLs, high CRP, you see that the event rate is 13% 3-year event rate for those patients. So I think this really reminds me that these are patients that we really have to be thinking about this concept of residual inflammatory risk, or patients who are still at quite high risk, despite having treated their other risk factors. These are, patients in a trial who are generally, healthier than some of the patients that we see. And now thinking about another group of patients, so those selected on the basis of elevated triglyceride, or this group of triglyceride trials. So this is an analysis of residual risk in patients in these 3 trials: Prominent, which is a Peña fibrate study, overall neutral study; Reduce It, it's like icosapent ethyl, which was a positive study; and then another neutral study, Strength. You can see here a similar story with those in the highest quartile of CRP having this graded risk for cardiovascular. I think this is cardiovascular death. Yeah, part of it is cut off too, but cardiovascular death, and really consistent across these 3 studies. And when you pool this data here, you can see here hazard ratio between 2 and 3 for cardiovascular death in those with elevated CRP, and you can see a more modest relationship here when we compare that to LDL. So a similar story, a different group of patients, but we're starting to see, I think, consistent data and thinking about residual risk in contemporary patients. And then thinking again about another high-risk subgroup, those we talked a little bit about CANTOS, but those with chronic kidney disease in this CANTOS sub-study. So we know that patients with chronic kidney disease are at elevated cardiovascular risk. We know that inflammation plays a role in these patients, both in the in the development, as we talked about, right, different organs, development of chronic kidney disease, and then the development of atherosclerotic vascular disease in patients with chronic kidney disease. So really a double hit. So those patients in CANTOS with chronic kidney disease versus without chronic kidney disease, we see here hazard ratio comparing the top to the bottom quartile of CRP about 1.5. And really for those patients with CKD, that the CRP was a marker of residual risk, whereas LDL was not in those patients. And we talked about this a little bit in thinking about the CRP as a downstream biomarker, but we know that there are the NLR. We have these signals that activate the NLRP inflammasome. From that, we get interleukin-1 beta secretion, interleukin-6, and then CRP as the thermometer, what we measure, in practice, to put patients in categories of risk. We talked about this already, but really just a reminder that we don't think CRP is causal really here, but something that's useful for us to measure in thinking about risk. And so some considerations when we are measuring this, I think we've gone through some of the data, but it is probably the most widely studied inflammatory biomarker. It is valid and reliable and generally stable over time. This is, of course, something we want to measure in stable outpatients, so more than a couple weeks out from some acute insult or infection or event. The high sensitivity assay is often measured in milligrams per liter. Something that does come up, that high sensitivity allows us to measure these lower levels of CRP. Though something that comes up from time to time is that what if I only have a regular CRP assay? If the CRP is elevated in those patients, it is a marker of inflammation and still very relevant. Like any other test, when you get a value, it's useful to repeat that value to make sure to confirm that it is elevated. And in the case of CRP, it's recommended that you use the lower of those two values. And these are data from, I believe, Framingham Heart Study, so showing really this graded risk associated with CRP for future cardiovascular events. The blue is unadjusted and the red is adjusted. But you can see over, even in patients with very high levels, which is, it's not you do see these patients in practice with, elevated levels. And of course we repeat, but those levels are still prognostic, okay. And this, I think, is now incorporated in several guidelines and practice guidance, the concept of measuring CRP, both American Heart Association, our prevention guidelines, and then those of the, some of the other societies like National Lipid Association and Preventive Cardiology. And so if we're thinking about who to measure, I guess, this conversation will probably evolve as we have more data. Right now, I think most of these guidelines and practice guidance focus on individuals who are currently not on statin therapy or, using it as a marker, risk-enhancing factor that favors starting therapy, so those who are borderline or intermediate risk. And then in secondary prevention, as we talked about, to assess residual inflammatory risk and make decisions regarding further therapy, understanding that may not be how we conducted trials. I think being realistic, we have many different therapies. We're talking right now about inflammation, but over the course of the next few days, right, you'll go to sessions and we'll talk about lipid-related risk. Dr. Libby started a discussion about obesity. We can have a discussion about A1C, and right, our patients are dealing with multitude of conditions, and many medications, and I think often don't take 5, 6, 7, 8, 9, 10 drugs. And so I think practically we do have to find a way to target, right, to think about what is my patient most at risk of and how can I reduce this patient's risk and really personalize, decisions about therapy for them. And so I think that really leads us also to think about how else we can personalize decision-making or personalize the discussion of inflammation and vascular inflammation. So there are, of course, soluble markers like HSCRP. We'll hear more about other markers like IL-6, and then there are. If we think about the vessel wall, there are other ways we can measure or think about, measuring inflammation. Some of these are FDG, right, radio-labeled glucose, sodium fluoride, this gallium dotatate. We'll hear more about pericoronary adipose tissue, and then coronary CT angiography, which we often use just for evaluating patients with chest pain. And so, each of these looks at or sort of gets at this question of vascular inflammation in a different way. Metabolic activity in the case of FDG, metabolically active cells, N1 macrophages in the case of the gallium dotatate, and microcalcifications with sodium fluoride. And I think this table sort of summarizes all the potential advantages and disadvantages. I think when we think about the potential advantages, one of the things that we're interested in is something that is reproducible, where we can monitor response to therapy. I think both for patient care, but then also when we think about how we design studies of the future. So, for example, FDG is something that we widely use in research, follow patients right with in oncology. Measure or look at metabolically active inflammatory cells, and has this potential response to therapy. Of course, there's a disadvantage of radiation, patient preparation. Patients can't exercise for 24 hours prior to the procedure. There's an issue with patients who have diabetes and glucose. There is myocardial uptake, which limits coronary imaging, and limited resolution. Then, of course, standardization of protocols and cost. And then more, we look at other modalities like this gallium dotatate, which might be more specific to these M1 pro-inflammatory macrophages and doesn't have this issue of myocardial spillover, higher specificity for plaque inflammation, and again, maybe a way to monitor response to therapy. And then sodium fluoride, which was used to monitor bone cancer, detects active microcalcification, so perhaps a way to measure this, active or early inflammatory phase, and in some studies has been shown to predict plaque progression and vulnerability. But again, we have to think about how these protocols are standardized and reliable. And then coronary CT angiography, of course, high resolution. We can identify high-risk plaque features, which may associate with active inflammation. We know has prognostic ability, but of course has the disadvantages also of radiation, needing contrast, and some operator dependence in in evaluating these high-risk plaque features. And so just to, I won't go through all the studies, but a few of them, we can look at data from the PISA study, which was done here in Spain, middle-aged people who are employees of the Santander Bank here in Spain. And what they did in this study, so of course that study, the idea is to monitor the development and progression of atherosclerosis using ultrasound and CT, non-contrast CT. They, in this sub-study, looked at patients who had evidence of atherosclerosis on one of those modalities and performed FDG PET in this sub-analysis of the main PISA study. And interestingly, they found using FDG PET that arterial inflammation was present in nearly half of these participants. The predictors of inflammation were things we might expect: age, obesity, smoking, male sex. And also very interesting is that while plaque was present, in many of these patients, there was FDG uptake in only 11% of plaques. So most of the FDG uptake in these patients were in plaque-free segments. So raising the question, of whether we were able to identify, early signs of inflammation that were precursors of the to the development of plaque. Of course, this is a cross-sectional study, so we don't have that information from this study, but hopefully longer-term follow-up of these participants will help us, answer that question. And common sites of the development of plaque here were the femoral iliac arteries. And then similarly, FDG PET can be used to predict recurrent stroke. And this is a study, a cohort of patients who had a recent stroke and underwent FDG PET, and showed that patients, again, with the highest quartile of plaque inflammation by SUV uptake, were at higher risk of recurrent stroke after the PET. So in thinking about who might benefit from either revascularization or, aggressive therapies, potentially a way to assess patients with recent events. And then sodium fluoride PET, which I mentioned, can be used to look at this active microcalcification in plaque. And so this was a study of patients with a recent MI 704 and plaque activity measured by sodium fluoride. And they found that plaque activity was not associated with this primary composite endpoint, but it was associated with the secondary endpoint of cardiac death or non-fatal MI. So just some take-home points. I think CRP is a valid, reliable biomarker. We have a wealth of data, although I've only highlighted some, supporting its prognostic ability. We should measure it as part of risk assessment. We talked about, we measure a number of other biomarkers like lipids, and now we're having a conversation about more routine measuring of ApoB and lipoprotein a. We can't even think about, how to treat this inflammatory risk if we're not measuring it. So measured as part of risk assessment. And that inflammation, as I showed you from those contemporary studies, is a key driver of residual risk. And while imaging techniques exist to measure vascular inflammation, I don't think these are ready for widespread clinical use, but I think that this is something that we'll continue to have a conversation about in thinking about how to personalize therapies for patients, thinking about who may benefit the most, and then of course in how we conduct, I think, trials in the future. So that's it.